Good morning, students. This is the third part of my chapter 35 PowerPoint explanations, and this begins with the very important topic cardiac biomarkers. Now, when you hear about cardiac biomarkers, the most important word which should come into your mind is troponin. Now, when cells are injured or uh, when there is uh, some kind of infarction, uh, the myocardial cells they release their contents into the circulation, into the blood circulation, and these contents they include some enzymes and some proteins. Now, these biomarkers, the enzymes and proteins, they are very useful in the diagnosis of myocardial injury and infarction. Now, cardiac specific troponin is a myocardial muscle protein which is released into circulation after injury or infarction. There are two subtypes, troponin T and troponin I. Now, and they are very specific to the myocardial tissue. Normally, the level of these in the blood is very low. So, a rise in level of these troponin is a diagnostic of myocardial injury. Now, troponin T and I, they are noticeable or detectable within hours of myocardial injury. So, on average of 4 to 6 hours, you can see their level rising in the circulation. And it peaks at 10 to 24 hours and can be detected for up to 10 to 14 days. Now, if you have any confusion about these numbers, on average of how to many hours they are detected, and then when do they peak, and how long they can stay detected in the body for how many days, refer to your EEG book. So usually on average it's 4 to 6 hours they are detectable, and they peak at 10 to 24 hours and then can be detected for up to 10 to 14 days. And troponin is the biomarker of choice in the diagnosis of MI, myocardial infarction. Let's go to the next slides. Now, um, we talked about troponin in the earlier slide. Now let's talk about CK, which is very famous, which is like abbreviated as CK, uh, which is creatine kinase. Now, creatine kinase or CK enzymes are found in a variety of organs and tissues, and they occur as three um, isozymes. Now, these isoenzymes, they are very specific to the skeletal muscle, brain and nervous tissue and the heart. So these CK enzymes, they are very specific to skeletal muscle found in our body, brain, nervous tissue and the heart. Now in the skeletal muscle, they are known as CKMM, and in brain and nervous tissue, they are known as CKBB, and in heart, they are known as CKMB. So we are concerned with CKMB because CKMB is cardiac specific, and it is its elevation is specific for MI or myocardial injury. CKMB levels begin to rise 3 to 6 hours after the symptom onset, and they peak in 12 to 24 hours, and then they return to baseline within 12 to 48 hours after MI. And the peak level and return to normal can be delayed in a person who has had a big MI, a large MI. Levels will drop more rapidly in patients who are quickly and they are successfully treated for an MI. So that's why we say uh, when we teach patients on warning signs of MI or heart attack, because it's not even heart attack, in even in stroke, there is always a window of opportunity, that is window of opportunity to save the patient. So the earlier detection is always helpful. What is myoglobin? Myoglobin is a low molecular weight protein which is found in cardiac and skeletal muscles. Um, and this is also a very sensitive indicator of very early myocardial injury, but it lacks specificity for MI. Um, so its usefulness in diagnosing MI is very limited, but they do mention myoglobin also as one of the uh, low importance uh, cardiac biomarkers. Now, if there is, if we need to, uh, if we want to use a diagnostic test, then correct interpretation of diagnostic test, it requires the consideration of the time from onset of the MI systems with the time of the expected presence and elevation of these biomarkers. We cannot we cannot negate the additional data like patient symptoms, history, and also the ECG changes to get the complete picture of this patient who is suspected to have an MI. Okay, let's go to the next slide. Now, uh, now, this is a graph which is showing you there is troponin, CKMB, and myoglobin. Um, now, you can see clearly that the red mountain, which is there, it's of troponin, and how clearly it starts from within, starts rising from within 1 to 5 hours, and it's getting peak between somewhere around 15 to 20 hours, and then it shows you with hours and how it started with hours on the x-axis, and then it's went up to days, like till 14 days. You can see the troponin level rise in the blood. And if you look at the green mountain, which is CKMB, there it shows that it's kind of rising along with troponin, but it is not significantly rising until 5 hours. Any significant rise in CKMB is mostly after 4 to 5 hours. So troponin will, if we have to use biomarkers, we will use troponin because that will be detected early than CKMB. So this is what they are showing you in the diagram. And I would expect you to know the um, level of troponin, uh, how many hours, after how many hours of MI it rises, its peak, and how many days it stays in their system. Or it might come across to you in a case study or scenario. So I can give you this. I might test you on this. Um, there is something, additional blood studies, there is something called C-reactive protein. And why we concerned with this? It is a protein which is produced by the liver and during periods of acute inflammation. And there is a high sensitivity test which measures the C-reactive protein, and increased level of C-reactive protein or CRP is an independent risk factor for coronary artery disease. Now, the level of CRP can also predict the risk for future cardiac events in patients who have unstable angina and MI. So, it's not sure, but they do say that the level of CRP can also predict the risk for future cardiac events in patients with unstable angina and MI. Regarding C-reactive protein, I would like you to remember what is C-reactive protein and why we need to know this. It's an independent risk factor for coronary artery disease. Now we have something called homocysteine, and the elevated levels, they show the increased risk for CAD again. And this is in like C-reactive protein is a protein. Homocysteine is an amino acid which is produced during protein catabolism. So elevated homocysteine levels can be either hereditary, like it can be the genes, or it can be acquired from dietary deficiencies of vitamin B6, B12, or folate. And elevated levels of homocysteine has also been linked to a high risk of CAD. Not only CAD, but also peripheral vascular disease and stroke. Now, who would be getting tested for homocysteine? It is recommended that homocysteine testing should be done on those patients who have a family kind of familial, like a hereditary tendency for early CVD, cardiovascular disease, or they have a history of CVD in the absence of any other common risk factors. So if they have a history of CVD or they have a family history of early CVD, then we might do homocysteine testing on the such patients. So as for homocysteine, I want to know what it is and what the elevated levels of homocysteine will indicate. Let's go to next slides. Then there you have cardiac natriuretic peptide markers, and there are three types, and they are popularly known as ANP, BNP, and CNP. So increased levels of BNP levels signify heart failure, and we talked about this in the other lecture. Now, these peptides, the ANP, A is for atrium and A is for ANP. So the ANP peptides comes from the atrium. BNP peptides come from the ventricles, and then and the C type peptides, they come from endothelial and renal epithelial cells. So, and BNP is the marker of choice for distinguishing a cardiac or respiratory cause of shortness of breath. So if there is a shortness of breath, then BNP would be helpful to determine if there is a cardiac or respiratory pathology underlying a certain shortness of breath in a patient. Um, Now they have also mentioned here NT-proBNP. You need not need to remember there. It is also some kind of peptide which is secreted into the ventricles and is more sensitive, but it's not more specific like BNP. Baby Nancy, uh, P is protein, so it's not as specific as BNP. for being a cardiac marker. So, and in this slide, I would expect you to know everything about BNP. Okay, what is BNP and where it comes from, and and uh, and if its level rises, what does it indicate? And also when diastolic blood pressure increases, you know, the other number in the blood pressure, when the diastolic blood pressure increases, which is mostly in heart failure, um, example heart failure, the BNP and this NT-proBNP are released, and they increase the like natriuresis. Um, Now, uh, we have been saying atrial natriuretic peptide, you know, B-type natriuretic peptide and C-type natriuretic peptide. Now, what is natriuretic? Natriuretic is excretion of sodium in the urine. So that's how it got the name natriuretic. So when diastolic blood pressure rises, example in heart failure, BNP, B as in baby, BNP and NT-proBNP are released, and they will increase the natriuresis, that is excretion of sodium in the urine, and that will also be indicative of cardiac um, disorder, disease, or pathology. Okay, so let's go to the next slide. Mm, Now this is about serum lipids, and it also showing lipoprotein. Now this slide and the next slide both are important for you, and so serum lipids, they consist of triglycerides, cholesterol, and phospholipids. And the triglycerides are the main storage form of lipids and make up to about 95% of our fatty tissue. So triglycerides are the main storage form of lipids, and they make up about 95% of fatty tissue. Cholesterol is also a structural it's a structural component of cell membrane and um, plasma lipoproteins, and it is a precursor of corticosteroids, sex hormones, and other kind of salts found in body. In addition to being absorbed from food in the GI, cholesterol can also be synthesized in the liver. So um, it's a structural cholesterol is a structural component of cell membranes and plasma lipoproteins. Phospholipids, it contains a lot of fatty acids, phosphates, glycerol, and other nitrogenous compounds. And although formed in most of the cells, phospholipids usually enters the circulation as lipoproteins synthesized by the liver. Now, serum lipids, they circulate in the blood bound to a protein. Thus, they are often referred to as lipoproteins. So lipids, serum lipids, circulate. Now, I don't need to explain you what is serum. By the fourth semester, the terms plasma and serum should be very clear to you. So, serum lipids, they circulate in the blood bound to a protein, and thus they are often referred to as lipoproteins. Uh, okay, so that's why we get the name lipoproteins. Let's go to the next slide. There are four classes of lipoproteins. Uh, chylomicrons, LDLs, HDLs, and VLDLs. So now, why there are so many classes of lipoproteins? Because they contain different amounts of naturally occurring lipids. So chylomicrons, and these are exogenous, or they are triglycerides from dietary fat. LDLs, they are mostly cholesterol with moderate amounts of phospholipids. HDL is about one half protein and one half phospholipids and cholesterol. VLDL, they are primarily uh, triglycerides with moderate amounts of phospholipids and cholesterol. So if a doctor orders a lipid panel, it will usually measure cholesterol, triglyceride, LDL, and HDL. Now this is the now what I'm saying is the important part. So now we know what is lipoprotein, and they have different types. But when the doctor orders, there is a lipid panel which usually measures cholesterol, triglyceride, LDL, and HDL. Now, elevations in triglycerides and LDLs are strongly associated with CAD. Um, an increased HDL level is associated with a decreased risk of CAD. That's why we say we want the HDL numbers to rise and LDL and triglycerides number to go low. So elevations in triglycerides and LDLs are strongly associated with CAD, which is coronary artery disease, and an increase in HDL is strongly associated with a decreased risk of CAD. High levels of HDLs, they serve as they have a protective role. What they will do, they will mobilize the cholesterols from tissues. Uh, Now, although they say there is an association between high serum cholesterol and CAD, a measure of total cholesterol alone is not sufficient for an assessment of CAD. A good risk assessment is calculated by comparing the total cholesterol to HDL ratio over time. So an increase in the ratio indicates increased risk. This provides more information than either value alone. So the patient, either value alone. So we want high levels of HDLs and low levels of triglycerides and LDL. And the patient must fast before the blood is drawn for a lipid panel to remove the effects of a recent meal. So when you have a lipid panel, what do you tell your patient? So he must fast because we don't want the effect of his recent meal in the blood draw. Okay, so let's go to the next slide. I think I will skip this. I don't want to do. This is also more explanation of uh, different kinds of lipoproteins. So it's going more deep. So I don't think I would go on this one. I would be more interested in this slide and this slide. So, okay. Now there is some questions. Um, right, a patient arrives at an urgent care center after experiencing unrelenting substernal and epigastric pain and pressure for about 12 hours. The nurse reviews lab results with the understanding that at this point in time, an MI would be indicated by peak levels of what? So they are all the lab biomarkers I have explained to you is all there: troponin T, homocysteine, creatine kinase MB, type B, natriuretic peptide. So the answer is very clear. It's troponin T. Make sure you remember troponin T. So troponin Troponin is the biomarker of choice in the diagnosis of MI. So we see homocysteine, we see creatine kinase, type B, but troponin is the most preferred uh, choice for diagnosing MI, and it is a myocardial muscle protein released into the circulation after the injury, myocardial injury. And the troponin levels they peak at 10 to 24 hours. Let's go to the next slide. This is showing you, it's a radiographic picture of the chest, and it is showing you all the cardiac uh, contours like curves, then the heart size, and then uh, any changes in the individual chambers. So you see there is an arch of aorta, pulmonary trunk, right atrium, then there is apex of heart, superior vena cava, left ventricle. So this is this is a um, chest X-ray picture, and the chest X-ray will clearly see if there is any displacement or enlargement of the heart, or is there if there any presence of an extra fluid around the heart, or if there is any lung congestion. So the chest ray or the picture is very helpful in detecting or in diagnosing the primary disorder. So let's go to the next slide. Um, Electrocardiogram. Now, this is another diagnostic study. The basic PQRST waveforms, they are used to assess the cardiac activity. Deviations from the normal sinus rhythm can indicate problems in heart function. So the normal sinus rhythm is the normal rhythm in the normal human being. Okay, so there are many types of electrocardiographic monitoring, and including resting 12 lead ECG. Then there is something called ambulatory ECG monitoring, and then there is exercise or stress testing, and these are all trying to assess the cardiac activity. Um, the continuous ambulatory ECG monitoring is very popularly known as Holter monitoring, and it can provide diagnostic information over a greater period of time than a resting 12 lead ECG. Uh, when you have uh, um, what I was trying to say. Okay, yes, Holter monitors. It has happened many times if you're working in the clinic with the cardiac clinics. Yes, it has happened many times that the patient has a lot of symptoms and doctor wants to do and check do the electrocardiogram, and then the leads are placed, and then but they don't see any abnormal activity at that time. But then the doctor decides, how about this? I gave him an ambulatory ECG monitoring system, which is Holter monitor, and he can take home, and then for the period of 24 hours or something, the this monitor will record his cardiac activity, and then we can determine whether he has any dysrhythmia or not. So that's why Holter monitoring is very important. Um, there is something called event monitor or loop recorder. It is used to document less frequent ECG events. An event monitor is a portable unit that uses electrodes to store ECG data once triggered by the patient. Disadvantage of this type of monitoring is that if symptoms occur for only a brief time, they may be over before the patient puts on the device and triggers it to record. So this is not used that much. Um, Cardiac symptoms frequently occur only with activity due to the demand on the coronary arteries to provide more oxygen. So exercise testing is used to evaluate the heart's response to physical stress. These helps to assess This helps to assess the CVD, which is cardiovascular disease, and sets limits for exercise programs. Exercise testing is used for individuals who do not have restrictions related to walking or using a bicycle. Now, exercise stress testing is another way to um, ascertain or to determine if the heart is healthy or if there is any impending CVD. Um, you'll be surprised in some of the hospitals, uh, when they have to when you have to, before employment, when you have to go through your physical, they ask you to lift certain weight, like 30 pounds, 40 pounds weight, because they are trying to see if the nurse is physically fit, and they'll ask you to pick some weight. And then some of them will ask you to go on a treadmill and run a walk, and they will keep increasing the speed of the your treadmill, and they will watch you for a while, and that's what their doctors are there. So even for the job of RN, sometimes uh, they do in some places stress testing. So that was interesting, and I had to go through one of these, so I remember. I remember that. um, okay, let's go to the next slide. So um, now we have our echocardiogram. The echocardiogram uses ultrasound waves to record the movement of the structures of the heart. In the normal heart, ultrasonic sound waves directed at the heart are reflected back in typical configurations. Um, um, so a contrast echocardiography involves the addition of an IV contrast agent. So there is an IV contrast agent also involved, which assists in defining the images, especially in technically difficult patients, in obese patients. So what does echocardiogram do? So, well, echocardiogram is ultrasound of heart. It can be with or without contrast, and it provides information regarding structures and motion of heart. It also measures ejection fraction. It also measures ejection fraction too. Um, um, Now, the there is something called transesophageal echo. Now, transesophageal echo, it's in your book. It provides more precise echocardiography of the heart than 2D echocardiography by removing interference from the chest walls and lungs. Uh, it uses a flexible endoscope probe and with a transducer in the tip for imaging of the heart and great vessels. And the probe is passed into the esophagus to the level of the heart, and then the image is obtained. Now, TEE will not be done on the patient who has a history of esophageal disorders, dysphagia, or radiation therapy to the chest walls. Patients require sedation during a TEE. So, um, I would say uh, memorize or know the nursing responsibilities during these tests: TEE, stress echocardiography, and echocardiogram. So, what is the nurse's role in these tests? Um, Two commonly used types of echocardiograms are the motion mode echocardiogram and the 2D cardiogram. So the one is called M mode and 2D. In the M mode type, a single ultrasound beam is directed towards the heart, recording the motion of the intracardiac structures. and as well as knowing if how thick are the walls and the chamber size. The 2D echocardiogram, it it sweeps the ultrasound beam through an arc, producing a cross-sectional view. So 2D gives a cross-sectional view, and the M mode type cardiogram is directed towards the heart and records the motion of the structures inside, as well as the thickness of the walls. So this is just good to know. You should know this, but I won't be testing you on M mode or 2D. There is something called nuclear cardiology, and then there is something called cardiovascular MRI, and there is something called cardiac computed tomography. Now, um, nuclear cardiology. One of the most common nuclear imaging tests is the multi-gated acquisition or cardiac blood pool scan. This test provides information on wall motion during systole and diastole, cardiac valves, and ejection fraction. So nuclear cardiology is a nuclear imaging test, and this test provides information on wall motion, that is heart wall motion during systole and diastole, information on cardiac valves and ejection fraction. Okay. Um, then stress perfusion imaging. Perfusion imaging is also used with exercise testing to determine whether the coronary blood flow changes with increased activity. So stress perfusion imaging may show an abnormality even when a resting image is normal. So this procedure is used to diagnose CAD, and it makes a prognosis in existing CAD or differentiate uh, any scar tissue in the heart. So, and then you have something called cardiovascular MRI. Cardiovascular MRI can detect and find areas of MI in a 3D view. So you want to know what part of the heart got injured. So MRI can do it. It is sensitive enough to even find small MRs um, that are not um, visible through cardiac computed tomography. So cardiovascular MRI is helpful in even detecting a small uh, MI or small injured tissue in the heart. Now, cardiac computed tomography, it uses technology, CT's technology, with or without IV contrast to see the heart structure, its circulation, and also big blood vessels, example aorta, pulmonary veins, and arteries. This technology is often called um, uh, CT scanning. Types of CT scans used to diagnose heart disease include coronary CT angiography and calcium score screening heart scan. So the common one which we all know is CT scans. It's called CT scan, which we are all aware of. CT uh, angiography is a non-invasive test. It can be done faster than a cardiac catheterization with less risk and discomfort to the patient. The calcium score screening heart scan is used to find calcium deposits in plaque in the coronary arteries. So the most common method used is there is an electron beam, and it can detect early coronary circulation before the symptoms can develop. So the calcium score screening heart, it looks for the calcium in the plaque deposits in the arteries. So um, just know what these um, just know what these diagnostic studies are, their definition, and what is the nurse's responsibility in this. Um, this is an image of left anterior descending artery. So where you see the large arrow, there they are showing the calcification of the left anterior descending coronary artery. So there is becoming like plaques are depositing in that artery. So that's why it's seen from the image. And then there is a small arrow which shows the uh, calcification of circumflex artery. So this is the picture of electron beam computed tomography. Okay, so they are showing plaque deposits in the arteries. Now, diagnostic studies of cardiovascular system. Cardiac catheterization is a very common word and all of you have heard it many times. I did give you some notes on this in the class. It is an outpatient procedure. It provides information about coronary artery disease, coronary spasms, any valvular heart disease, any ventricular function. Um, Now, for the um, with injection of contrast media and fluoroscopy, the coronary arteries can be seen, chambers of the heart can be outlined, and wall motion can be observed. Now, cardiac catheterization is done by inserting a radioplaque catheter into the right or left side of the heart. For the right side of the heart, a catheter is inserted through an arm vein or leg vein. So it is now during the class, I think Dagan or Jamie, they were saying it is vein or artery. Now the access is through the vein, but it reaches the artery. So I said vein, artery, and it was towards the end of the class. So let me explain you clearly how it was. Um, so suppose we have to um, uh, we want to know something about the right side of the heart. So what will happen? A doctor, the cardiac uh, physician, he will insert a catheter through an arm vein, so which is basilic or cephalic vein or a leg vein. So they are inserted through a vein and then pressures are recorded as the catheter is moved into the vena cava, the right atrium, the right ventricle, and the pulmonary artery. The catheter is then moved until it is lodged in position. This blocks the blood flow and pressure from the right side of the heart and looks ahead through the pulmonary capillary bed to the pressure in the left side of the heart. So they are looking at the pulmonary artery occlusive pressure. So this pressure assesses the function of the left side of the heart. So for the right side of the heart, a catheter is inserted through an arm vein or leg vein. Arm vein can be basilic or cephalic. And then the pressures are recorded as the catheter is moved into the vena cava, the right atrium, the right ventricle, and the pulmonary artery. The catheter is then lodged in its position. This blocks the blood flow and pressure from the right side of the heart, and it looks ahead through the pulmonary capillary bed to the pressure in the left side of the heart, which is pulmonary artery occlusive pressure. And this pressure assesses the function of the left side of the heart. So how the left heart catheterization is done. The left heart catheterization is done by inserting a catheter into a femoral or brachial artery. And then the catheter is passed in a uh, retrograde manner up to the aorta, across the aortic valve and into the left ventricle. So uh, you can in the class I will draw a picture where I will show how the cardiac catheterization is done for the uh, right side and left side of the heart. Now, coronary angiography, it is done with the left-sided heart is done with left-sided heart catheterization, and the catheter is positioned at the origin of the coronary arteries, and a contrast medium is injected into the arteries. The patient in coronary angiography will feel a temporary flushed sensation with dye injection. Um, with cardiac catheterization, I would be more interested in knowing if you're working in this outpatient cardiac cath clinic, what is the nurse's responsibility? Okay, so, and of course, as I said in the class, also complications will include bleeding or hematoma at the puncture site, any allergic reaction to the contrast media, um, any infection, any uh, any accidental puncture of the ventricles, or any lung tissue got damaged or something. So noting for any change after this procedure, and also how the nurse will prepare or educate the patient before and after this catheterization. Um, the basic thing which we are uh, aiming by doing this cardiac catheterization is we want to know if there is any disease, cardiac disease, coronary artery disease, if there is valves are damaged, if there is ventricular dysfunction, or is there any coronary spasms happening, and we also want to measure the pressure inside the whole cardiac structure, intracardiac pressure, and also the oxygen level, as well as the level of carbon dioxide, or any even how the injection fraction is going on. So cardiac catheterization gives you a lot of information. Um, in the class, I think I said that cardiac catheterization measure pressures. Uh, to be more specific, right-sided of the cardiac catheterization is to measure pressure, and left-sided to evaluate coronary arteries. Um, uh, at this point of time, just know the purpose of cardiac catheterization, how it is done, and what's the process and all that. We can go over this again in the class. Okay. So the end result, we want to know what is happening in the arteries, in the coronary arteries. Okay. So let's go to the uh, next slide. And they are just showing you in this, they're just showing you a picture of normal left coronary artery angiogram. So this is our complex artery, and that's how it should look. There is other studies, intracoronary ultrasound, fractional flow reserve, and electrophysiology study. You can read for the uh, read it from the book, but I won't be testing you on this. A question: a patient returns to the cardiac observation area following a cardiac cath with coronary angiography. Which of the following assessment require immediate action by the nurse? So his pedal pulses are 2 plus on both sides. Apical pulse is 54 beats per minute. Mean arterial pressure is 72, and ST segment elevation uh, is developing on the ECG. Now ST elevation on EG, so PQRST, so the portion from S to T, you see in the graph, PQRST, the portion from S to T, it will elevate. That means the curve will go up. And if it's go up on ECG, it indicates MI, or injury with partial or total occlusion of coronary artery. So The answer is 4. But ST segment elevation always is associated, usually most of the time it is associated with MI. And just remember this because many times in NCLEX this question comes a lot. ST segment elevation or ST elevation, and this is MI. And this can suggest partial or total occlusion of coronary arteries. And this requires immediate action by the nurse. Actions would include assessment for chest pain, putting on the 12-lead ECG, administration of nitroglycerin or morphine, and notification of the doctor. Now, if the pedal pulses are 2 plus on both sides, we will do assessment, but it's not that critical unless the patient is symptomatic, which is chest pain, shortness of breath, or low BP. And options 2 and 3, as you know, is normal finding because uh, it's not that uh, significant. Yes, you all will say that apical pulse is 54 beats per minute, but this can be normal too. So the most alarming here option is ST segment elevation, which is showing MI. Okay, let's go. So there are no more slides. And we come to the end of the chapter 35 PowerPoint explanation. Now, I will be posting a couple of more videos, and this will be mostly directed towards the dysrhythmias chapter. Um, I think during the next clinical, so you will be playing with some uh, EKG leads, so it will be an interesting skills lab on next Thursday, and Miss Janice will update you on this. Um, if I were you, I would be doing my readings during these 4 days from the book, listening to my e-lectures, memorizing the cardiac drugs, the cardiac AHA drugs which I posted. And I think doing all this will take your 4 days. Okay. Um, okay, thank you.